Hey, this is Ash from All Things Dentistry, the place where we're passionate about sharing those unwritten hints and tips of dentistry. Well, let's tackle this maxillary molar, first molar, really calcified, and this is a kind of like real life, like what you're going to experience likely in your practice. Patient comes in, emergency patient, you've got a limited window of time to tackle this tooth. You can take a look at the radiograph right here and see it's actually fairly calcified. And one of the things you need to do and highly recommend is taking a look at the bite wing radiograph. That will give you a better clue as to the level of calcification in that tooth. So what we're going to do is we'll walk through this case. Now, if you're doing these routinely or that's amazing. If you're not, what I highly recommend is finding some extracted teeth and tackle these with extracted teeth because they're really hard to do, managing a patient, all of the things about with symptomatic irreversible pulpitis, and let alone just trying to get into the tooth. So let's go ahead and get started. One of the tips that I learned from a viewer online actually was to dry your tooth before you're placing these light cured secondary seal, like Cool Dam. I usually use oral seal, but in the operatory that I was working in for this case, I found some Cool Dam. Like, hey, dang it, let's try this out. And sure enough, drying the tooth, short of putting bonding agent, but drying the tooth made that stuff stick all the way to the end. And if you stick around to the end, just like the classic YouTuber, you'll see me peel it off. Yay. Anyways, let's go ahead and light cure this Cool Dam and let's get started. So the patient was diagnosed with actually it was necrotic. Sorry, this was a necrotic tooth with a symptomatic apical periodontitis, fairly calcified. For a stable reference point, for a variety of reasons, what I highly recommend is flattening the tooth. Now you don't need to take it down, right down 2 millimeters, but this tooth will be restored with either a direct or indirect restoration, cuspal coverage, and as well for a variety, like I said, a variety of reasons. We're going to take it out of occlusion. One, it's so the patient isn't biting on it, so it decreases the amount of pain. There's an article by Rosenberg a number of years ago that talks about that. Another one actually is for just during the practicality of doing a root canal is stable reference points, like repeatable. You've got a flat plane. Look at these flat cusps now. It makes life so much easier when you're trying to get a stable, a repeatable working length. So I'd highly recommend, if you're restoring the tooth as well, go ahead and flatten those cusps just a little bit. And then, because it will only save you down the road in terms of efficiency, because as my buddy at Les says, endo is fiddledontics. You can fiddle away your time. We all know that, just doing ridiculous things repeatedly, and we don't even know we're wasting that time. So what I'm going to do here is I'm just actually using this amalgam to trace down into where the pulp chamber is. Normally what I'll do is I'll use any type of restorative material as kind of a path, because it's a really quick way to cheat to get to where I need to go. And then I'm using that diamond burr just because it was in my handpiece as I was using it. But what we're going to do now, I think, and I literally just did this case, we're going to use, oh yes, that's right. Normally we use a number 4 round surgical burr. As I was thinking about voicing this case over and presenting it to you, I was thinking with calcified teeth, actually in endo in dentistry in general, you never know what you're going to get. And look at this, calcified tooth, and yet we hit the palatal pulp horn. I couldn't believe it. And I was like, oh my gosh, this is a gift from the endo gods. And one of the things that I do at this moment is I validate my diagnosis because there's no hemorrhage coming from this little perforation into the pulp chamber.
So rather than to use the normal long surgical round carbide burr, what I like to do here is use that long shank diamond burr. And the reason why I'm doing that, well, partly because I already was using it, but also because I already figured out where the pulp chamber was. I'm just brushing away the roof of the pulp chamber, just nice and light, just to expose the calcification, because we know there's a calcification under there.
Here, that's all pulp stones. So if we set this case up, this is the mesial, distal, palate. I should have said that before, but I didn't. Here we go. Palate, And this is kind of what we're aiming for, MB1. There's our distal buccal, kind of, and our palate. Now this upper 6 is very interesting because it's a little more constricted. It's almost like a 7, especially when I was looking at the radiographs, and I was kind of like, interesting. So normally what I'll do is I'm going to, and this is exactly what I'm doing here, is we're just going to go dry. I've slowed this burr down to 100,000 RPMs, and if you can use an electric handpiece to do that, it's really helpful. But I'm literally just brushing the walls and trying to kind of pick up any pulp stones that might be loose. That's really what I'm doing. And I'm just lightly brushing on top of that large pulp stone because I'm trying to see if I can vibrate any of the pieces. Is it a whole? The question is, are they attached or unattached dental pulp stones or denticles or whatever you want to call them? And is it one big chunk or is it a whole bunch of little ones? So at this point, because I don't really have my ultrasonic, and I'm kind of like, you know what? I don't know what's what. And as you can see here, like, I mean, look at this. This just looks like, you've got debris in and amongst pulp stones. One of the quickest ways I find to figure out where things are is just to take my wave on gold. And what I'll do is I'm just going to use that to start to triangulate kind of where the where the canals are. So now I know there's our palate. So I'm like, okay, boom, we are in the money. I mean, it's obvious that we're in the right area. Nothing's bleeding, like we haven't perfed. However, it just adds to the level of confidence by just, instead of just tackling, rather than just tackling, trying to get all these pulp stones out, I'm like, you know what, let's try to figure out where are some of our canals. And what I love about reciprocation is that it doesn't really want to dig, it's not going to be digging holes in the teeth. It's more just kind of like snuffing out the pulp, the canals as it goes. So what you'll see here is I'm using the Wave and Gold Small just because it was out, and we're just give it a shot. And what actually happens here, I'm like, okay, sweet. Reciprocation just is looking for somewhere to go. Otherwise, it will just either not go or just bend. So I've got two canals. I'm not worried about reciprocation perfect. That's another reason why I do this. Rather than try to use a round burr and try to uncover things, I'm just using it to triangulate, try to get my foot in the door and figure out, okay, what's going on. Now, one of the things I don't know is this the mesiobuccal or is this the distal buccal? I still don't know. I mean, obviously I know now. I finished the case and we finished pulpectomy, but I have no idea at this moment. And as you can see, what I have here is a large pulp stone. So what we're going to do is I don't normally use ultrasonics for just a regular access. I guess I should, but I mean, I have them. But I find that they kind of slow things down. Maybe if the case is really calcified, I'll use it. But what I'll do here is I'll typically just take the diamond and just burn through all of that, just lightly brush. And what it does is it does two things. I find it vibrates, but it also just grinds it down, just like a big rock grinder, if you may, in the micro version. So I'll just take my diamond burr at 100,000 RPMs and I'm just lightly brushing, and that kind of vibrates it out and grinds it and does everything else. And it's important. My experience has been, I mean, it's not always perfect, every case. But what I find is that if you spend the time looking for the pulp stones and getting them out at the access time, it then less and less pieces of pulp stone end up down the end of the canal. That's been my experience, but they still may. You can clean and shape and still have pulp tissue or pulp stones floating all over the place. So I'd like to spend a little bit of time while the orifices are not completely opened up to try to get some of those pulp stones out. Because I can tell you, I'm sure, put in the comments below if you've been, I mean, we've all been blocked out. Hell, that's almost daily. But have you been blocked out by a piece of pulp stone that flew down the canal? You didn't even know it. And then at some point, you're doing your cleaning, shaping, or irrigating or something, all of a sudden a pulp stone flies up, and you're like, whoa, where did that come from? Well, that's definitely happened here. I don't even need to put in the comments. I'll just tell you right out. So what we're doing here is we're irrigating until our irrigant is clear. And I'm actually, it looks like my irrigating needle is quite psychotic. Actually, what I'm doing is I'm kind of bouncing it off the walls, kind of brushing the walls to get any debris or material, whatnot, flushed out of the pulp chamber. And actually, what you can see here are some more pulp stones that are hiding underneath. And that's very common, I find. There's going to be sometimes if there's a little bit of, right, especially in the palate, they hide. So there's some pulp stone. Let's go ahead and fish that out of there. Look at this. All pulp stone. All almost calcified pulp, if you may. I couldn't even tell you. And what happens, I find, is it gets stuck under this little like pulp horn lip here. That's what it is, and they just sit there until you're taking your paper points. You've cleaned and shaped everything, and then you take your paper points, and all of a sudden, boom! It's like I'm blocked. Like what happened? It's like the paper point hooks it and takes it down with it. I don't know. That's just my hypothesis. So again, we're going to irrigate all of that material out. So one of the other reason why I love to open the coronal 2/3 and orifice open at the same time is, using less files. But if this was a hemorrhagic case, what happens is you're removing all of that pulp out of that canal, or not all of it, but a good portion of it to help you then start identifying other canals. Less hemorrhage makes life so much easier. Okay, so I don't know. I'm assuming. So what I was taught in residency was, and it makes common sense, but until someone tells you, you never think about it. Um, Look when there are restorations this large, those pulp horns and canals around adjacent that restoration likely are going to be calcified. And sure enough, this is the distal buccal I'm thinking, and the reason why, there's a couple of reasons why. Look at the angle at which that file is headed. That looks like it's headed towards the distal buccal because the kind of the angle of exit of the files, usually from distal buccal, are leaning towards the mesial. So that kind of gave that clue. Second, this does not look like calcified pulp or anything like that around here. It looks like just the side of the tooth. And third, we've got that large restoration. Fourth, actually, we have a very constricted pulp chamber mesial distally. If we take a look at the bite wing, so I was kind of like, you know what, this looks like it's a really contracted, a really, not contracted, but a smaller, kind of more constricted pulp chamber that really mimics a 7. So let's go ahead and, actually, I was going to try to see if I can get that wave one gold into where that mesiobuccal area is, but I couldn't do it. Ooh, I shouldn't have told you that. So what I'm looking at right here, let's see if I can see it, is some calcified pulp tissue. It doesn't come up really well in the microscope. Well, it comes up in the scope, but when we're filming, it doesn't show. So I'm just pointing out to the person watching, is there's our distal buccal, that was our palate before. And then we're just looking for, yeah, so this right here, that looks like tooth structure. Not, it doesn't, obviously it's all tooth structure, but it doesn't look like calcified pulp. So for me to start digging to look and find where our distal buccal would be, say for example. So, and we haven't really removed much of that restoration. So I think, oh look, there's a little bit of a pulp stone right there. Right there, see that pop out? Oh, look at that, what a treat. So it definitely gives me another idea that there's probably some pulp down there. Another orifice, and there it is. So that is our mesiobuccal. You can see how constricted it's become after that restoration. So me being, kind of like, hey, let's show off here. Let's try to get that wave one gold in there. Let's try to do what we always do. Try to sneak that in there. So I bend my wave one gold small, and there we go. Boom. I mean, this is a magical file. Okay, didn't make it anywhere. Let's try it again. Right. I've got the right angle. And nothing. Third time's a charm. And nothing. Fourth time. Maybe. No. Fifth time. I didn't even realize I tried it 5 times. No go. And let's go ahead and use that diamond burr. So I've slowed it down again. It's still at 100,000 RPMs, and we're just going to slowly trough into where that mesiobuccal is. Nice and light. Now we're not going to burn away a lot of the coronal tooth structure. One of the things you can do, which I'm doing here, is I'm actually thinning out that restoration just to enable access. So thinning that out allows me to get better access into this area, and then just makes life so much easier. All right, so we're going to rinse all of that out of there. And then let's see. Okay, so let's take a look. We have, I think that's actually our orifice right there. And then we've got a little bit of debris. Let's go ahead and see if we can see anything better. Yeah, there's our orifice right there. All right, so we're going to open the coronal 2/3. We're just going to go to our cutting flutes, and then we're going to irrigate. So we're pretty much on track for finishing this pulpectomy in this emergency case. Now you may say, oh, well, you didn't tackle MB2. Honestly, we didn't have enough time. And my experience has been as long as we tackle the main canals, get our working lengths, arguably, so this is a necrotic tooth and there was a lesion. I mean, arguably, if this was a vital tooth, you could just do easily a pulpotomy. You could just open the coronal 2/3, remove the coronal pulp tissue, and the patient will be fine if you're going to refer. And there's so many different ways of doing it. Because this is necrotic, I'm going to make sure I clean and shape all the canals to at least a 25. And that's what I'm doing here. So we're just verifying our working lengths. This case was actually pretty straightforward in terms of like the canals were straight. Like this was the simplest molar I think I've had in a little bit. Usually you need to pre-bend files and everything else, but what we're going to do is I don't think there's much here other than just getting our working length and then taking our wave on gold small to length and then the primary. All right, so what we're going to do is we're going to take our small to our complete working length. And I'm actually going to take this, what I'm doing here is I've got our pulp chamber, my pulp chamber is full of irrigant. And then I'm not completely bringing my file all the way out. What I'm doing is I'm bringing it out into the irrigant. I've got this actually at 2-speed. So I'll bring the file out of the irrigant. Of course, I stop here. Okay. So this is a fresh file. So I asked for another file. So I'm taking my file, taking it down to length as far as I can go, and then I'm bringing it out into the irrigant, letting the flutes empty in the irrigant, and then back down. So the reason why I do this is just efficiency. I've done this long enough, and here's a secret for you, is that if you keep your pulp chamber full of irrigant, just the kind of the shake, just the absolute way reciprocation works, as you if you fill the flutes with debris, bring the file out into the irrigant, it just knocks it off. So you don't have to keep, what I find is that it prevents me from having to bring my file out repeatedly, clean it off back and forth, out of the canal back and forth. And what I'm trying to do is I'm just trying to save time. I'm not trying to make the case faster, but I'm trying to make it more efficient. So what happens is when there's a snag, then the time that I've saved by doing little movements efficiently, I'm going to just use that time to figure out the troubleshooting. That's really what happens. All right, so we're just going to make sure we have patency. Let's go ahead and keep going down with our yellow. So I'll go down, out, back down. This is at 2-speed as well. So working length is roughly like 19.5, if I can remember, 19.5 or 20. So see how much more efficient this is than bringing the file all the way out, cleaning it back and forth. But the real critical thing is that I'm letting the flutes empty, because it's really easy to fracture files due to cyclical fatigue by just keeping by torsional fatigue, by keeping the flutes full of debris. And then what happens is that the friction of the debris in the flutes actually builds up to a point where the friction grabs and the strength of the file is overcome by the friction and the file breaks. So one easy way to do that is just make sure your flutes are clean all the time. So recheck the working length, irrigate, and now my pulp chamber is full, and I'm going to take my primary down the length. And one of the other things about having irrigant in the pulp chamber is that it just like motor oil, water flows everywhere. I mean, you try to hold water in your hands, it's almost darn near impossible. And when you have irrigant in the pulp chamber, it's always flowing with you. It's going with the file apically as you take the file apically. So it's also disinfecting as well, because that's what we're looking for in this case. Because it's necrotic, we're trying to disinfect this canal as best as possible before we dry it and place our calcium hydroxide. It's hard to maintain disinfection if you're just clean shaping with a dry pulp chamber. I mean, just keep your pulp chamber full. It's like our new slogan. Full pulp chambers for everybody. Let's see. Let me think about that. Put in the comments below some sort of cheesy or but half serious slogan for about keeping your pulp chamber full. All right, so what I'm doing here is I'm just kind of recapitulating, kind of activating, if you may, what I'm trying to do is I'm knocking the debris back into solution. You could use an endo activator. I honestly found that just using a 10 file on plastic teeth, just experimenting with reevaluating for our advanced endo course, just kind of reevaluating activation. And I was like, wow, the endo activator doesn't work very well. I mean, it works, sure, whatever, do it. But honestly, one of the most effective simple techniques other than manual dynamic activation with a gutta percha point is just literally using a 10 file. I was so shocked. All right, mesiobuccal. This is where I'm going to trough. We're not going to do it at this appointment. This is really an emergency appointment. So this is where I'm going to be troughing, but we're going to get a cone beam, which will now help me discern whether or not I even need to trough. Probably will anyways, just to make sure, because sometimes the resolution of cone beams is not 100%. So there's our mesiobuccal. All right, so we're just going to use our paper points. And one of the things that I do routinely is I'll place my first paper points and then I will blow air across just to wick up any irrigant in the canals. And then also what it does is it dries out my pulp chamber, which is great too. So these paper points are really fine. They're the 2007s. So they are curling as I put them in. They're actually quite finicky. I don't normally use them, but we're just using them for this appointment. And I'm just checking to see if they're dry or wet. That's it. There's a little tip coming up that I was taught a long time ago, and I still want to make a short about it. It's actually bending them. I think you can see it here. If you're having a hard time putting your paper points into the canals, you can bend the tip of it and use the cotton forceps at an angle. See this? Really helpful. Didn't really need to do it in this patient, but what it allows you to do is kind of push of course I was trying to do it. I've got lots of other footage of me doing it. And of course, in the time that I actually voice it over and do the video, it doesn't work. The paper point folds. These are arguably way too small. Anyways, folding it, bending it really helps to get in, especially in really tight spaces. Okay, so we dried everything. Let's just take a look. Last little view. We've got our mesiobuccal. There's where I'd be troughing for MB2. There's actually a little pulp zone. Look at this. This little friend right there. I think that's a giveaway right there. I think there's a little pulp zone saying, hey, listen, that's where, come back next time I'm here, MB2. So I'm not going to flick that out of the way. I could be wrong though. I'm just showing the person that's watching this episode live. There's a distibuccal and there's a palate. So we've got a super clean pulp chamber. Now what we're going to do is just place some calcium hydroxide and then we will send the patient for a cone beam and then finish the case. Now, there's lots of different ways you can tackle this. Obviously, if you had the time, you could finish this in one. There was just not enough time in the appointment scheduled. You could, you know, let's going to place calcium hydroxide. I'm just placing it in the coronal 2/3 of the pulp chamber, and then we're going to run it down with usually a 10 file, but I was just like, you know what, I'm going to try my Wave and Gold small. I'm just going to spin it in reverse and pump it up and down. Just do that. Pretty simple. There's lots of different ways you can do this. But in terms of the overall procedural flow, you could, one of the gentlemen, Dr. Kevin Fryer, actually, what they do is they take a cone beam on all their patients on their entrance exam and enrollment exam or comprehensive exam, the initial exam of their appointments. And when they have cases like this, like today, they already have the cone beam. So even, the patient calls in, says, I've got a sore tooth. If they plan that it's going to be endo, he can just pull up the CBCT. It's already there, and he can evaluate the case. And I was like, wow, that's actually a great idea. That is, I don't think it's going to happen in my lifetime, but it'll be really simple. I mean, if you have a cone beam in your office, you could bang this out in one, fairly straightforward. But in this case, we're going to do a little more like kind of real life. Pulpectomy up front. Let's evaluate it, make sure the patient's symptoms resolve, and then we will get them back. I'm just placing composite here because it may be a little bit of a prolonged, maybe a month or two before we get the patient back. And from my own experience, I'm just going to tell you this. I really appreciate you sticking all the way to the end here. I had a bunch of onlays done on my mandibular teeth because I have a ton of cracked teeth. So I'm waiting to make a cracked teeth video because not only do I have clinical experience, I've got my own personal experience from bruxism and living with cracked teeth. And what you think, anyway, so I'm not going to get into that. It really changed my mind when I started experiencing symptoms of cracked teeth. So I have a bunch of onlays on my mandibular teeth. I've been there for a couple of years now. They're amazing. And when my buddy was adjusting my maxillary teeth, he just, we were doing it quickly, so he just adjusted with a fine diamond and then left it. And I can tell you that I had tons of food catch into those diamond grooves. You'd think like, oh, somebody adjusted your teeth with diamond. It must be amazing. Well, just the fineness caught a lot of food, and I'd have to scrape it out with my fingernail. Yeah, it's kind of gross, but it's life. So what I'm doing here actually is I'm just smoothing that off with just my endo Z-burr and just giving us a finer finish just in case. I mean, maybe I'm just a princess, if I can say that today, but maybe I'm just weak. So that might be just me getting food. Maybe most people probably doesn't bother them, but just food for thought that if you're using a heavy diamond or something like that to adjust these, you might want to just smooth them off with a flame burr or something like carbide. And what I'm doing here is I'm actually just beveling this sharp edge because it can be fairly sharp as well. Anyways, I'm so grateful you made it to the end. You should be proud of yourself. I'm super grateful you're here. Put a comment below. Let me know you're here, and we will talk to you soon. Cheers.
Hey, Asher, and I wanted to take a second of your time just to introduce our course, Root Canal Like an Endodontist. We've had it for a couple years, and we've had some amazing successes through it. Just confidence building on behalf of our students. And really what happened was a few years ago, I wanted to create a course to help others because I know what it's like on your endo journey. A lot of times you don't know what's going on. You don't know if you've ledged it. You don't know what to do if you blocked it. You don't even know if a curved canal, what to do. And what I wanted to do was take all my mistakes and my training from my residency and put it into a affordable online course for everyone around the world to join in. And it's been absolutely amazing. And I wanted to offer to you, check us out at allthingsendo.ca. Once you join the course, you get access into our private Facebook group where all of us answer questions. And I'm telling you, there are questions every day that you might be able to, I'm sure you'll be able to connect with, because sometimes it just takes a little bit of courage to ask a question and then your outcome may be incredible. Anyways, I look forward to seeing you there. allthingsendo.ca. We'll talk to you soon.